Welcome to This Explainer. Today, we're tackling a high-yield board review on neuroanesthesia, and we're going to approach it by looking at the human brain as if it were a high-performance engine. To keep this incredibly demanding machine running smoothly, especially under the intense stress of surgery and anesthesia, you have to master precise fuel delivery, oil consistency, and throttle management. Because honestly, if any of these get thrown out of balance, the results can be absolutely catastrophic. So we're going to break down the most critical, highly testable physiological principles from the latest literature to give you total clarity on how to protect the brain in the OR. Okay, let's dive into this. Here's our mental map for today's explainer, the 5 physiological pillars you're about to master. We'll start with viscosity and hematocrit, move into why cardiac output drives cerebral blood flow, examine the vulnerable aging brain, decode the CBF-CMR coupling axis, and finally, bring it all together with clinical integration. Section 1. Viscosity and optimal hematocrit. Let's start with our engine's oil consistency. When we talk about the flow of blood through the delicate cerebral vasculature, we're really talking about viscosity, and the single most important determinant of blood viscosity is your patient's hematocrit. Now, burn this number into your memory, 30 to 34%. You see, in healthy humans, normal hematocrit variations don't actually change cerebral blood flow much. But in a patient with focal cerebral ischemia, where the brain's blood vessels are already maximally dilated to try and desperately get more oxygen, viscosity becomes everything. The literature clearly shows us that dropping the hematocrit to that 30 to 34% range provides the absolute optimal delivery of oxygen to those at-risk tissues. It strikes this perfect balance between keeping the blood thin enough to flow past blockages while maintaining enough red blood cells to actually carry the oxygen. But here is where we need to bust an outdated clinical myth. You might logically think, well, if thinner blood flows better, we should purposefully dilute the blood for everyone having a stroke, right? No, absolutely not. While patients with severe polycythemia, meaning a hematocrit greater than 55%, absolutely do benefit from hemodilution to reduce viscosity and improve flow, doing this for a patient with an acute ischemic stroke does not improve their outcomes. In fact, manipulating viscosity in acute stroke is strictly not recommended. The risk of decreasing the blood's oxygen-carrying capacity far outweighs any potential flow benefits. And this brilliantly illustrates exactly why. When we compare arterial oxygen content reduction, notice how hypoxemia basically skyrockets the flow response. When the brain experiences hypoxemic hypoxia, there is a massive, aggressive compensatory increase in cerebral blood flow. Because of this, total cerebral oxygen delivery is far better maintained during hypoxemia than it is during hemodilution. Hemodilution simply doesn't trigger that same robust protective flow response. Moving to Section 2, cardiac output drives CBF. This brings us to our fuel pump. Historically, anesthesiologists have been kind of obsessed with mean arterial pressure, or MAP, as the sole driver of cerebral blood flow. But modern evidence points to another critical, historically underappreciated determinant: cardiac output. To put some hard numbers to this, research has demonstrated a really powerful link here. If your patient suffers a 30% reduction in cardiac output, that independently drives a roughly 10% decrease in cerebral blood flow. And this happens independently of blood pressure or CO2 levels. Plus, in patients with cardiac failure, their autoregulatory capacity is already impaired. So this relationship is incredibly relevant in the operating room during low-volume states, hemorrhage, or shock. Think about it. If the heart isn't pumping out the volume, the brain isn't getting the flow, even if you chemically squeeze the blood vessels to make the map look perfectly normal on your monitor. Focus on maintaining adequate circulating volume and cardiac output, not just the map. Let's see how this builds into our clinical choices, specifically regarding our vasopressors. Imagine you've got a hypotensive patient with poor cardiac reserve. If you immediately reach for a pure alpha-1 agonist like phenylephrine, yeah, you'll increase systemic vascular resistance and make your MAP number look great. But by increasing the cardiac afterload, you can actually further decrease the cardiac output, which ironically compromises cerebral blood flow even more. Instead, after optimizing volume, reaching for an agent like ephedrine or dopamine, which increases both MAP and cardiac output, might be far preferable to protect that patient's brain. Section 3. The vulnerable aging brain. Now we really need to talk about the physical engine block itself, and specifically what happens as it ages. Because the physiologic background of an 80-year-old patient is vastly different from a 30-year-old, making their brain exquisitely sensitive to perioperative ischemia and the suppressive effects of anesthesia. Now, what's really staggering about this is the sheer scale of structural and metabolic decline.
By age 80, the brain has undergone about a 10% loss in actual neurons and a massive 25 to 35% reduction in dendritic spines. Because there's literally less brain tissue firing, both baseline cerebral blood flow and the cerebral metabolic rate for oxygen drop by 15 to 20%. On top of all that, this older brain suffers a reduced cerebral vascular responsiveness to both PaCO2 and hypoxia. This is a system operating with virtually no reserve. Section 4. The CBF-CMR coupling axis. This leads us perfectly into the ultimate mechanism of throttle management. In a healthy brain, blood flow and metabolic demand are tightly linked. When the brain works harder, blood flow increases. When it rests, flow decreases. Every single neuroanesthesia decision you make hinges directly on this flow-metabolism coupling axis. Let's quickly define two critical, heavily tested terms related to this axis. Luxury perfusion happens when anesthetic agents decrease the brain's metabolic demand but actually increase cerebral blood flow, so you have high supply and low demand. This can be protective during global ischemia. But contrast that with the steal phenomenon. In a patient with focal ischemia, like a localized stroke, the blood vessels in the ischemic area are already maximally dilated. If you give a volatile anesthetic that vasodilates the whole brain, the healthy vessels open wide, and blood flow takes the path of least resistance, literally stealing blood away from the ischemic area that desperately needs it.
Section 5. Board review, clinical integration. So the crucial point is how we pull all these physiological threads together for rapid-fire clinical decision-making at the head of the bed.
Here's the stark clinical contrast you absolutely need to remember. Intravenous anesthetics, like propofol and barbiturates, are your cerebroprotective best friends. They reduce the metabolic rate while preserving that delicate coupling axis, making them extremely ICP-friendly. Volatile agents, on the other hand, well, they're a double-edged sword. At high doses, they uncouple flow from metabolism. They actively vasodilate the cerebral vessels, raising total cerebral blood volume. And inside a rigid skull, that dangerously raises intracranial pressure. So you must carefully titrate your volatile dose alongside ventilation, your PaCO2, and your MAP to maintain balance. And to do this safely, we rely on monitoring tools to give us real-time inference of blood flow adequacy. Tools like jugular venous oxygen saturation, where normal is 60 to 70%, regional cerebral oxygen saturation, aiming for 55 to 80%, and transcranial Doppler of the middle cerebral artery. Though, remember, each of these tools definitely has its own limitations.
And that is the beauty of understanding the deep physiology behind the guidelines. You aren't just memorizing rules, you're truly understanding the machine. So I'll leave you with this. Knowing that pure vasoconstrictors can choke off cardiac output, and that volatile gases can steal flow from ischemic tissues while raising ICP, how will this modern view of the flow metabolism axis change the way you manage your very next hypotensive neurosurgical patient? Think about the pump, the oil, and the throttle. Thanks for joining me on this explainer, and keep learning.